stroke team, and I met in Rochester at a New York State Department of Health officiated, I guess, Coverdell stroke meeting, where people from all over upstate New York gathered to talk about stroke systems of care and how to optimize delivery of care to stroke patients, be they in far rural areas or in urban areas, near or far to comprehensive stroke centers. It was actually, I don't know, Richard, correct me if you're wrong, but I thought it was a really productive meeting, and it actually will be published at some point over the course of the next couple months, which is going to be really nice, because getting that amount of brain trust in one room, it was paramedics and regional EMS personnel and nurses and stroke coordinators and physicians, both EMS physicians as well as endovascular and regular stroke neurologists. It was a fascinating group of people. So it was an excellent meeting. And out of that conversation that Dr. Brooks and I had, we thought we should convene a meeting here of the brain trust, really, of emergency medical services for our 6-county region, which we realize bleeds over a little bit farther into other regions, to make sure that we're optimizing care for our stroke patients here as well. So what I'd like to do, just so everybody has a better idea of who is who, I'd like to go around the room and just brief introduction, who you are, what agency you're here representing, what hospital, so that our guests, both Dr. Boulos, who's one of our neurosurgeons from Albany Med, and Dr. Brooks, and everybody else can have a good idea of who we are. So, I'm Mike Daly. Hi. Dean.
Peter Romano, and I'm QI coordinator here.
Jay Tyler, I'm the senior paramedic supervisor for the town of Gilliland.
Brian Wood, I'm the captain of the Albany County Sheriff's Office EMS Division.
Mike Breen, Deputy Chief, Police Rescue Squad.
Mike Potter, Deputy Chief, Police Rescue Squad.
Frank Denays, Chief of the Emergency Department of St. Peters. I'm Scott Bowman, I'm the Chief at Police Rescue Squad.
Tim Morali, Executive Director here at REMAC.
Bruce Eschkow, Director of Emergency Critical Care at Samaritan, and I'm Medical Director for assorted EMS agencies ranging from BLS, CFR to ALS and other combinations thereof.
Brief.
Brief as I keep it.
Ken Dott, Sabic Ambulance.
Don Doinell, physician at St. Peter's ED and multiple medical directors for
Sarah Vogel, full-time landmark for DM Albany Memorial ER for 14.5 years.
Sam Moscow, Emergency Medicine, St. Peters, former chief at St. Peters.
Matt Miles, Emergency Medicine physician, Landmark Health, and Ellis Medicine.
Mary Ramon, State Health Department.
Carol Grant with Mohawk Ambulance.
Nick Rather, Albany Med, ER, and several different medical director hats.
Steve Hassett, Albany Med, ER, and several medical hats.
Heidi Cordy, also Albany Med.
Robert Huemeister, LCR, and several.
Greg Conrad Fox, ALS coordinator for Rescue Squad.
Alan Boulos, Chief of Neurosurgery at Albany Med, and endovascular neurosurgery.
Okay.
Ben Seymour, student help skill paramedic instructor.
Thank you, Fred.
Fred Fowler, Chief of General Schuyler EMS.
Kevin Robert, Clinical Manager, Clifton Park Half Moon EMS.
Margie Panetta at Ellis, I'm the Stroke Program Director.
Bob Dox, Chair Emergency Department at Ellis Hospital.
Richard Brooks, Chief of Neurology and Head of the Stroke Program at Ellis Hospital.
Andy Medani, Chief of Neurology, St. Peter's.
Catherine Griswold, Emergency Medicine Physician at St. Mary's in Troy, and Medical Director for Troy.
Wow. That's fantastic. What a group. So, I guess the best place for us to start really would be the fact that everybody's here. Seems like this is a good idea. And the preface that I sent out to the MAC yesterday was that this is very similar to where we were back in 2005 or 6 when we started looking at STEMI systems of care and making sure that our community hospitals would not be losing all their chest pain patients to centers that did percutaneous angioplasty, and frankly that the centers that did PCI didn't necessarily want all those chest pain patients either. We have good care available in a lot of different places, We have specialty care available in only one place. I think I'd like to start, if I could, with a little perspective from Dr. Boulos, and then Dr. Brooks, if you'd step in after that. Is that okay? Thank you. Now,
So I've been a neurosurgeon at Albany Med since 2002. I did a fellowship in endovascular training before that in Buffalo. And so I've gotten to see the evolution of the endovascular treatment for stroke from the beginning, so to speak, where we're using basically cardiac technology and trying to apply it to the brain with mixed results. 2004 or 5, the first endovascular cath devices were made that allowed us to retrieve these clots. Got FDA approval based on their safety, but we never really could show better outcomes in stroke until really this past year, where the latest iteration of devices, the stent retriever devices, were able to show in repeated studies across the globe benefits in stroke outcomes. And what that meant was a twofold increase in your chance of a good clinical outcome in the worst strokes possible. And that's why I think it also sits with what Dr. Daly said about we're not looking for all the strokes. The segment of stroke patients we're talking about are really the most severe kind, the large vessel occlusions in the brain that will benefit from a procedure like this. They're also the ones that have the worst prognosis. They're the ones that have a very high mortality rate and a good clinical outcome rate, less than 1 in 4, less than 25% without treatment. And so the trials were similarly designed in all the different countries, basically giving IVTPA versus IVTPA in a device, and the device being an interventional device, and it showed that the interventional device was superior in those 4 trials across the globe. And so the question about IVTPA was also solved in these trials. We still give IVTPA the full dose. It doesn't seem to be a risk for bleeding. It allows us to continue to go on to do the endovascular procedure. And the other advent that occurred during this time was a better selection process for the patients. And so the last couple trials, which had the most significant benefits for their patients, used perfusion imaging to try to decide on who should go to the endovascular suite and who shouldn't. And by using perfusion imaging, they were able to select the patients that already had a completed stroke and exclude them from going to intervention because they had a higher risk for bleeding and a lower chance of having a better clinical outcome. And we were in the American trial called SWIFT Prime, and we continue to do we still use that same protocol since the trial ended in 2013 and 14, and I think with good results. Now, having said that, our subgroup community, the endovascular community, is looking at continuing to treat patients, wake-up strokes, other conditions where we don't know the time of onset, and just using the perfusion map to determine candidacy, also with good results. And so the criteria are somewhat mixed, but what's clear is you have to have a large vessel occlusion to be a candidate, and that's usually the MCA or one of its major branches. The vessel usually has to be 2 millimeters or greater in diameter so the devices can work. The anterior cerebral artery, and then the basilar artery and the vertebral artery. Now, the basilar artery and vertebral artery were not included in the trials that I'm speaking of. They were not part of the randomized trials. But prior to those randomized trials, those were considered the best cases for intervention because they were also the ones with the worst prognosis. So the mortality rate with a basilar occlusion was upwards of 80 to 90%, and good clinical outcome was less than 5% if you were already in a coma from the basilar artery occlusion. And so those cases were felt to be ideal endovascular cases even before we had these newer devices. So what we do today is we use the SWIFT Prime protocol, which allows us to do the CT, CTA, CT perfusion in the ER when they come to Albany Med. The CT perfusion goes through what we call a rapid software, and then the email goes out to the entire team, which shows us a blood flow map. It shows us the reduction in blood flow, the core, that's a result of the cerebral blood volume going down, and then that determines the candidacy of that patient as it relates to the SWIFT Prime algorithm, which is if the core is less than a third of the threatened territory where the blood flow is reduced, then those are good candidates for the procedure. If the core, if the area that's already infarcted appears to be greater than 1/3 of the territory at risk, then they're excluded from the endovascular procedure. That's the current kind of state of of this field. Some are starting to already argue about, is it worth still taking those patients to try to reduce the stroke size, even if it doesn't produce necessarily a clinical outcome benefit, because it might avoid craniotomy, it might avoid intensive care unit stay. So there is still some debate on what I just spoke to, but in general, that's the protocol that we're using.
Thank you. Thank you. Dr. Brooks or Dr. Cox, do you want to speak to it at this point, or your perspective?
Just a couple of comments.
Please.
I think everybody would agree that this type of interventional procedures are important, but it's not likely that most hospitals in the community are going to be doing them. Because, you know, you can't have one interventionalist, you really have to have a team of intervention. You have to be available 24 hours, 7 days a week. And you have to do enough of them to develop a level of expertise. So I think it's safe to say that in the foreseeable future, Albany Medical Center is probably going to be the only place that will be doing this. So, you know, as Dr. Bulow said, you know, our goal is to make sure that the patients who benefit from this get to where they need to be to get this done. I'm not aware, I mean, I stand to be corrected, but I don't believe that at this point in time, we have the tools to be sure in the field whether a patient has a large artery occlusion or not. You may have your suspicions, but you can have somebody with a very bad stroke and it turns out it's a bleed or something that would clearly not be a candidate for this sort of thing. So most often they're going to be brought to the nearest emergency department where they have you know, the capability of giving TPA, doing the CAT scan, and doing the routine things that we need to do. And then, you know, it's up at our institution, it's up to the neurologists and emergency staff to try to select as best we're able those patients that need to be transferred. And it's important that they get the TPA intravenously as quickly as possible and not delay that, because oftentimes they're not a candidate for intervention once they get to Albany Med. So, I mean, one of the reasons I'm here is to do anything we can to, you know, once we've found that the patient may be a candidate for transfer, to facilitate that transfer and make it happen as quickly as possible. Because multiple recent studies have shown that if you're going to do these interventions, that the sooner you do it, the better the outcome. A delay of an hour or two makes a significant difference. So that's basically why we're here.
Thank you. Any other quick comments at this point? Sam?
You know, there's also probably a subgroup of patients that we haven't talked about here that would fall into the benefit of in the neurology and neurosurgery. People can comment further, but just within the past week, I mean, I had a fairly young person who came in with an altered mental status, and they had a subarachnoid bleed from a temporal artery, temporal lobe aneurysm. And these type of patients are also patients that may be very beneficial in transferring for percutaneous intervention, especially since I'm not confident that any neurosurgeon in the area are opening heads for this anymore, you know. So I think that's another subcategory of patients we just might want to keep in mind when we're discussing percutaneous intervention and getting the right subgroups of patients to Albany Med to the hands of Dr. Boulos' service.
Thoughts on?
Yeah, I mean, those are both great points. You know, we are a team of three attendings. There's a fellowship. And as was mentioned, it's a huge effort beyond just the doctors in terms of the infrastructural support to get these patients, much like a cardiac cath intervention is. But because it's a relatively new procedure, getting the angio nurses and techs comfortable with these procedures is not straightforward. It took us a while to get to the point where that's now an established routine event. And so I totally agree with what Dr. Brooks said regarding that. And I think it remains to be seen, but I think time is so much of the essence with stroke, further than even the STEMI, you know, in my opinion. And so I think it will remain to be seen whether the transfer times can be shortened to the point where as he said, there's been several cases that Alice has sent us, and they've done it as quickly as possible, yet they come with already infarcted brain, and we can't do the intervention. And so we're gonna keep looking to improve that, and I think that's a critical piece if we're gonna make a difference.
I think the thing that we all face with stroke, and it's something that the Department of Health has talked about a lot in the past, it's just the fact of whether or not strokes are being identified well in the field. We talked about this a little bit prior to this meeting. The Department of Health, under the previous Coverdell group, was looking at EMS times and EMS recognition of strokes, and we're trying to drill down as to whether or not EMS was recognizing strokes and getting strokes to stroke centers in a timely manner. They weren't able to actually elucidate any data that showed that EMS wasn't doing a good job. I think we all know who does the lousiest job of identifying strokes, and that's the patient who's having the stroke. They do a lousy job, and you know, they are really, really good at denying that anything's actually going on. So we've got to get past that first, Frank, and then Sarah.
So I just had one question regarding the field of diagnosis. If I receive a REMO call about a patient with a dense left hemiparesis and a rightward gaze with a known time of onset, and they want to bring the patient to me at St. Peter's, and there's a question maybe that they're on an anticoagulant, which for the patient, that can mean aspirin, right, as far as we know, because they don't really know the difference sometimes. But, so this patient could have a bleed, or they have an MCA territory stroke that's probably large. I mean, would it be fair to say, or reasonable for me to say on that REMO call, hey, you might want to go to Albany Med for this. This sounds like, you know, an MCA territory stroke that's large, and I think there's not much, and by the way, if he's on Eliquis, or she's on Eliquis, or some other anticoagulant, I can't give him TPA anyway. There's nothing I can do for them. So if they know those things, so this is a guided call. This isn't just, you know, the paramedics making the call themselves. So if you get I happen to have one a month ago where I didn't get a remote call. The patient arrived, and he actually was on Eliquis. They didn't know what he was on. Did a CT, and then got the transfer going. BLS agency actually took the patient all Albany Med. They happened to be there, and went with a nurse. So it was a very good situation. The patient went from that, what I described, dense hemiparesis, got a thrombectomy, and was walking and talking the next day. I mean, it was unbelievable. So I don't know how people feel about that if we get a remote call. Bruce, Don,
Well, actually, we'll
make
it fun.
Explanation of the question. It's your location allows you to do that. The other thing you have to think of is, are we going to kill Albany Med with patients that are not going to be of benefit to this? Already the parking times, because you're not familiar with parking, that's when the ambulance providers are waiting and to get the bed. They're just sort of parking at the desk. I mean, already just day to day, it's what, 45 minutes sometimes, hour. We have to get the right patient to the right resource at the right time. I think you made a great clinical judgment. That's not something I really want to park on the EMS providers. With your direction and depending where you are, that makes sense. Which is a nice lead into one of the questions I was going to ask, which, very similar to STEMI, one of the great advantages is the first talk with the paramedic and the transmission of the EKG, where the team can be gathering and building. So the team is coming in, getting ready, as the patient is still coming in and not yet arrived in the emergency department. Which then begs the question, does it make sense for the community hospitals to have the appropriate phasing software in their computers where they can do the CT, CTA, all of the things that you need, and then we establish it's the right candidate immediately, then send them. Those people who are not candidates stay, those people who are candidates go. Those who are going, we know they're going to go upstairs, possibly even bypassing PD if you're ready to take them, or a short park time, very similar to the way that we handle STEM. So what's your thought on that? Or should we just wait till we get our standard CT, CTA, and then call, and then do a transfer? Would earlier imaging help?
Yeah, so, I mean, there are a couple different questions that were asked. In my heart, I think that patient who you know has multiple signs of a large vessel occlusion could be redirected, and maybe that's the fastest way to get the treatment. Admittedly, it could be a hemorrhage when they get here, but as was said,
we can't do the coil anyway.
Hemorrhage would be just as good.
Right.
Yeah.
Okay, well,
Yeah.
that's
So
the
it's
other
two
big
birds with one
differential
stone.
typically for that condition. in terms of if the patient's there, what are the right imaging choices to make? Again, speed and time is the key. So for us at Albany Med, getting from that just a non-con head CT to getting all those 3 studies done at once with it being read right away was quite a challenge. So the infrastructure around that wasn't as simple as I'd hoped it would be. So I think if there's a lot of delays getting those studies, then it's certainly not worth it, right? Getting the CAT scan everyone's routinely doing that for the primary stroke center certification and has a good method for that. Adding the CTA, CTP is quite a bit more on the tech, the radiology tech, and then the interpretation of those films subsequently. And if that ends up with a major delay getting the patient, it's certainly not worth it.
Actually, if I can just stop for a quick second. One of the things that's interesting that Frank said really made me think back to our original meetings about STEMI, which was that you had gotten the call, you said, well, I don't think this is a patient for me. I think that there's a potential, if you had gotten that call, this is a potential that this patient should go somewhere else. And what we had originally asked EMS to do with STEMIs was if the patient wants to go to a non-STEMI center, then it should be actually the community hospital they want to go to should be the one that does that remote call. So that the redirection is based on the facility that they're originally intending to go to and the physician judgment there. Because you're not refusing the patient, you're redirecting the patient for different care. Right? And I think, if I remember correctly, Sarah, it was you talked about the most from Memorial's perspective on the patient with STEMI. We don't want the ones with the STEMI, right? We want the chest pain patients, right? So that was just to bring back 10 years of memories for you. All right, sorry, Dr. Brooks.
Yeah, the only comment I would also make about that transfer of the patient, in that situation, clearly that was the right decision because, there were things available that you didn't have available. But if it was a patient who was a candidate for IV TPA and there was going to be an extra half hour or 40 minutes in an ambulance to get IV TPA, you have to weigh the pluses and minuses of that delay. I mean, they may get to Albany and there was a 40-minute delay in getting IV TPA and they're not a candidate for an intervention, because a lot of them are not. So when you're dealing with St. Peter's and Albany Med, where the transfer times aren't going to be significantly different, but if you're talking about coming from Fulton or Montgomery County, and it's going to be an extra 45 minutes in an ambulance, that has to be figured in.
It makes a lot of sense. Or the city of Schenectady right outside of Ellis, or frankly the city of Saratoga right outside of Saratoga Hospital. But
yeah, I got a couple of comments about the transfer. It was a great clinical call, but I have a couple of major concerns. That I don't think without delineated protocols, we have ER docs discussing with the patient, with EMS on phone, to start redirecting. I think that's dangerous in a number of ways. One is this person probably needs some intervention, but as we know, the vast majority, the overwhelming majority of patients with stroke are not applicable for interventions. In fact, the large studies use well less than single-digit numbers of patients who are actually eligible for this. So to start
in any randomized
phone
trial,
calls, what's that? Sorry?
That's because it was a randomized trial, though,
right? Exactly.
Not
but
all stroke.
I think, but nonetheless, I'll bring back whether there's a large numbers or small numbers. Let's just take it. You don't want to start redirecting with just phone calls without a protocol. That's my first comment. The second comment I have is that because you can get deluge down there if that starts happening, one, and two, there'll start to be the potential of what I like to call indication creep. That is, EMS says, I'm not even going to call St. Peter's anymore. I'm just going to come down the med. Why am I even wasting my time? That happens now at Ellis. People go right past St. Mary's, go right past the Loversville Hospital, because we're a stroke center. We get these people who are a little confused. They possibly a stroke. They come to the stroke center. So without definitive protocols, I'd be apprehensive about. You may break home call, but I'd be apprehensive about making that call just over the wires.
I think some of that, the gestalt of the call is going to be an important part of it. But you're absolutely right of the indication creep, and I think that's real. That's real.
I think we're looking at making this sort of like the STEMI, like trauma. It's going to be a X amount of time between closest hospital, closest stroke center, and Albany Med for EMS, and part of that would be a flag with if your patient is known to be taking an anticoagulant, call the closest for direction. Just like you call the trauma center, or call the closest hospital for direction with a trauma.
Ken?
You know, I think the biggest hurdle here is us as EMS providers. Number one, we're dealing with a patient who may have a significant stroke that we're looking at saying, wow, this could be a large vessel stroke, saying, you may benefit from going to Albany Med, versus the patient who's a little bit confused saying, this could be an early onset, should we go to the closest hospital, see if they need care, and what's the transfer time? And then we're dealing with the patient who says, well, listen, I don't go to that hospital because of whatever, and I want to go to this hospital, you know? And again, for us, we have multiple hurdles to jump over to try to figure out, well, what's best for the patient, what's going to satisfy the patient's needs, and what's the patient's request on top of all that. So, you know, I think education, once everything gets kind of sorted out on your guys' level, you know, then bring it down to our level and say, look, here's the criteria. If you have somebody meeting X, Y, and Z, it's recommended they go to this facility. But if they don't meet X, Y, and Z versus the criteria for a large vessel stroke, take them to the closest place and let them figure it out, kind of thing.
It's basically going to say closest place because no one has come up with a decision rule that's
Right.
remotely applicable to pre-hospital.
Right.
So it's going to stay as suspected stroke, yes, no, and then if you're so far away and you know they're taking Eliquis, consider a renal call.
Right.
Interesting, it's done.
I guess the question is, for all those folks who are out of the time frame, you guys are doing this up to about 6 hours, correct?
So again, according to the SWIFT Prime protocol, it was 6 hours for anterior circulation strokes, but we use the perfusion data for wake-up strokes, and we'll use it outside the window.
So, I mean, sort of our problem is, when I've called down to the med, I've gotten two separate directions. One is send the patient down and we'll do all the studies down there other than the dry scan we've done. The other is, well, get the scan and then we'll see if there's something that's applicable, which takes a lot of time. I mean, basically it's sending them back to the CT scanner, giving them contrast, and then after that, having it read and then talking to you guys again. So if time is of an essence, it would seem more reasonable that if they are past our time frame and they have a reasonable stroke, that they should head to you guys to get the studies, and we'll take them back if you don't.
That's definitely my preference, because of what you just described. And also, the reality is, if you get a perfusion study that's favorable, it doesn't mean an hour or 2 hours later when they arrive at my ER that the perfusion was favorable.
Right.
So, for me, it's better to get the perfusion closer to the time of the treatment, which is at our ER. So that is my preference. Unless a hospital is doing all 3 studies at the first admission to the CAT scanner, when the stroke comes in, that's a different scenario, but that would be the only way I could see it being worthwhile at all.
Does anyone
That
have
would
a
be really
selection
the key
protocol
question
to do
is,
that?
should the community
There
hospitals
is
gear up to do
scales,
that?
preclinical scales, the race score, and others that are trying to.
How long does it take to do the perfusion
Dr.
study?
Dunn, sir.
How long it takes to do the perfusion study?
The perfusion study itself is less than 5 minutes.
Okay.
Go
So,
ahead.
this is the way I see it. The primary treatment remains IV TPA. We need to identify those patients who need to have endovascular procedure. So the majority of strokes who are not really clear, dense hemiplegia with eye and head deviation are probably going to be IV TPA. The critical thing is to identify those patients who need to bypass the local hospital to Albany Med, and that's going to depend a lot on the information that the physician gets from the people in the field. And this is where the difficult decisions got to be. Otherwise, stroke patients can still arrive to the primary stroke center, get the studies done quickly, and transfer if needed. So you don't get overwhelmed with everything too.
Dr. Brooks?
Part of the picture, though, is in the event that the patient ends up where endovascular is done, what can we do to expedite transfer to Albany? And that's one of the reasons I'm here, is because we have had instances where, unfortunately, with some delay, where the patient was dropped off and assessed, and within 15 or 20 minutes, it's determined that this is somebody who might benefit from transfer, and then we have to wait and call an ambulance, and there is a delay sometimes, not all the time, but sometimes. So recently we were having a discussion about that. I mean, in those patients that look like they would be candidates for transfer, and you can identify those pretty quickly after arrival, it would be, is there a possibility of having the ambulance remain on site, ready to transfer the patient as soon as certain things have been ruled out? And that doesn't take terribly long. I'd say 15 to 20 minutes probably. So that would certainly expedite it. And we also talked about issues, if we hang the IVTPA and ship, which doesn't take long, does a nurse have to be in the ambulance? And is that going to pose an issue for ERs that have shortage of nursing, or that could pose an obstacle? So those are some of the practical, logistical issues that we're trying to address.
I think right now you're bringing up some of the things that I think this body has the most opportunity to address. And those things are frankly items that can be changed. I'm not sure that we're going to end up with the stroke equivalent of an EKG anytime soon. And regardless of whether or not CMT is thinking about putting on a stroke ambulance to cover the 88 corridor, I don't see that happening anytime soon. Even though New York Presbyterian now has a stroke ambulance patrolling the Upper East Side. And I understand that they have now given TPA in the stroke ambulance at least once within 2 blocks of New York Presbyterian's emergency department. So I'm not really sure what to gain. What? 7 times now. So I am relatively sure that Scott's fiscal prudence inhalation will not lead to a $1 million ambulance in Northern Columbia County anytime soon.
It's over 7.
What?
I was just pointing out that this is recorded, right?
Of course.
Never mind.
We will note, though, that the EMS fellow is about to start is a fully credentialed ultrasonographer, so that may make some interesting opportunities for us. Please, Mark.
One of the things that to kind of carry on what Dr. Brooks was saying, just this week we met with Carol and Dan and Sean from Mohawk. We get a lot of patients coming to us from Mohawk, but we also get patients from Rotterdam, from Niskayuna, from volunteers, and we were trying to hash out with them some ideas, because the volunteers particularly, or even the paid people in small communities, they might only have 1 ambulance. So they aren't in a position to be able to be identified, wait till we do a quick CT, rule out bleed, and kind of do a quick thing and then send them on to Albany. They're not able to do that. We are working with Mohawk to see if we can work out something, because as Dr. Brooks said, that was the biggest issue. It's not, and Dr. Boulos had said about this CTA, they've told us, point blank, don't bother taking the time to do the CTA. We're going to repeat it anyway, probably. So our thing is, like, if we're going to identify the person, let's get them out of here as quickly as possible. And that's what we're going to focus on, working with the folks from Mohawk right now. So I'd be interested to hear some feedback on that. What do you think about, it's the transfer time that's the issue.
So I mean, somebody could go to the local hospital, get the IVTPA or not, and in 10 minutes be back in the ambulance on the way to Albany. A lot of this would be sort of a moot point.
So among the things that we've been working with here over the course of the last year has been Mission Lifeline STEMI. And one of the things that very quickly came from those meetings was the opportunity for best practices sharing. And St. Mary's in Amsterdam, in particular, working with the Ellis cardiologists, has put together a fantastic door-in, door-out program that has also been borrowed by some other hospitals. Greg and Dr. Nandi brought it into Columbia County almost immediately after one of those meetings to say, all right, a STEMI leaving Columbia Memorial and going to Albany for intervention is a priority 1 call. So it bumped to the top, right, of the process. You want to talk about that real quick?
Yeah, it's a activation that meets criteria. Scott Bowman was a big part of that too when we brought it to the Ambulance Association. It meets criteria for the ER physician to say it's a STEMI or it's a CVA that needs advanced intervention, it's not available. And they all hang the TPA, and we'll get there, TPA will be done, and we take them right up. So it's that activation with 911. They dial 911, they have critical transport out of CMH, we get there within a couple of minutes, even if it's a standby rig, and there's very little time. Our goal is door in, door out 10 minutes. So that limits it to about a 15-minute turnaround from the time of activation, the time of us on the road to St. Peter's or Albany Med for that.
Skinner County has a protocol in place with 911 that if Mohawk is delayed for any reason, it's 911, and you'll get Mohawk BLS specific fire if they have a BLS truck available. Otherwise, you get Rotterdam and Niski unit. So that's already in place. It's been in place for about 2 years now. Yep. So you just have to call 911 if there's any delay with Mohawk.
The goal being, when we do emergency medical dispatch on calls in just about every public safety answering point, and someone who's got a sprained ankle and is sitting waiting for an ambulance can keep on sitting and waiting for an ambulance if there's somebody in a hospital that needs a critical intervention and needs to get moved. I see lots of shaking heads from everybody.
We're just coming to
Yeah,
that, and
absolutely.
it's gonna be STEMI, stroke, sepsis, trauma.
Mhm.
And there's no diversion of those ambulances for interfacility transfers to a 911.
Mhm. So those interfacilities bump the 911 call, except the high priority 911 call, which makes sense, which makes really good sense. So we can put that in place. The other interesting question that came up, and this is one that several of us have talked about, is, and Don just mentioned the idea of, or maybe it was Frank, of getting a nurse in that ambulance, right, with the TPA.
I thought we discussed that we would consider that along the lines of heparin. Since it's an anticoagulant medication, we would consider it going on the same protocol, so we would not need to send a nurse.
I think that's exactly where we had gotten to.
Yeah.
Because frankly, if there's a bleed, you put pressure on it. If it's a bleed you can't see, there's nothing anybody's gonna do to fix it in the back of an ambulance. You need to go where you're going. Right.
Just stop the TPA.
Mhm. Right.
So I understood that a nurse had to go. It's not true.
It's not true. It was a couple months ago we had discussions. The only time they would need a nurse is particularly if we're doing vasoactive medications. Outside of metoprolol, you would need a specialty care medic, so that might, if you're spending them on Cleveprex or if you're sending them on nicardipine, that would need a nurse if you can't get a specialty care. And honestly, if Mohawk doesn't have the Glenville truck in town, you're not gonna get a specialty care truck in any kind of manner, so you're gonna have to spend nurses that run compressors, or vasoactive medications. If they're just getting TPA, they don't need a nurse.
You know, we probably should amend the protocols that have TPA in there, 'cause as far as I know, there isn't that.
Let's clarify it through an advisory is probably the best way to do it.
Or to clarify, it would be fine.
Mhm. Well, actually, first, before we clarify it, we have discussed it before.
Yeah.
Is there anybody in the room that dissents from that?
And we also spoke with all the EMS agencies that typically come to us and resource dependent. They all agreed to stay if we tell them to.
Okay, great.
I don't think this is widespread throughout the region, though. I think these are very good relationships that have been worked out, I think, in local catchment areas, but are not really applicable across the whole region.
Mhm.
So I think, outside of the discussion today, it probably calls for more discussion and trying to protocolize some of these things that have worked well in other areas.
No, that makes a lot of sense, yeah. I
ER
think,
level, not so much EMS, because a lot more of getting the imaging online, getting the protocols for the imaging, more of the ER to ER to neurology to decide what to do. And once they agree what they're gonna do, then we can build an EMS protocol around that.
well, I think that,
I'm talking about, though, the organization that you've done and the organization that Columbia has done relative to transports and agreements on how all that works for critical inter-facility transfers and so forth. I think that's the piece that is not applicable across the region and needs further discussion.
so in terms of that, and one of my bullet points here is, Tim and I both sent letters to the Heart Association in pursuit of a New York Health Foundation grant to be one of the first sites to do Mission Lifeline Stroke, which would enable us to get information around the door in, door out times, and then share that data and best practices across the region the same way we've been doing with STEMI over the course of the last 18 months. And hopefully we will land that grant and be able to move forward on it. I think that if not, we should make that a specific quality assurance project for this organization, because that's really the role that we play. It's nice that the Heart Association has been stepping in and assisting us with some of this. The bottom line is this is the care of the patients that we're all interested in best practices for, and we should continue to share that. So we'll look to make that process move forward. One of the things that Don and I talked about earlier is the fact that every hospital in the region can't upload CT scans to each other yet. And that's something that we very much need to make sure happens in order to facilitate best care of a patient. Don should not have to burn a disc to send a patient 1.25 miles, if it's even 1.25 miles, I'm not sure it is. But we should find a way to open those pathways up. And I think if we regionally send a letter asking for that to happen, and then potentially exercise some of that at the state level through Don, that may be very helpful as well. I have a quick sheet that I'm just going to hand to the docs real quick if you want to comment on it as we go. So this is a draft of a transfer form that I felt would work well for the sending physicians. And if you look, probably the most important thing is the piece on the bottom. So, goal ultimately is to get as much information transferred as easily as possible. This is a draft that I wrote up as part of a project that I was doing somewhere else, and has not been approved by the XX Access Center that you'll notice at the bottom. All right. So from an emergency medicine perspective, it's important the MD Calc modified NIH stroke score is on here. That's actually a clickable link on the original document. Does something like this make sense to be filled out quickly for that patient to go? Or is this going to be too difficult? So you pick up the phone and you call the Access Center at the Med. They fax you a copy of this, or there is a link available for you to complete this online. So you can click through and hit that NIH stroke score. So you've got all of this there. Most important thing is the question of what the prior modified Rankin score on this patient is, which basically is this a patient that will benefit? That should actually be 0 or 2, shouldn't it? Not 0 to 3, right? So 0 to 2 will have the most benefit. And then, is this all something reasonable? The idea to remind nursing, we'll draw a creatinine, you don't have to wait till the result comes back. And then at the bottom, is the patient accepted for return transfer? Some centers will be stroke centers, will be able to take a patient back, and some won't. Is this something that's workable in your environment? Or is this something that's going to be unnecessary busy work and just create higgledy-piggledy? Bruce?
I think you started to hit the nail right on the head. I think it's a great checklist,
Mm-hmm.
and I think that it should be used as a document by the clinician and nursing to make sure they have all the pieces of the puzzle. If you look at our standard transfers that we send out, all the key information is there, written right in your HPI. So this would be redundant work.
Mm-hmm.
It would all be sitting in our scribed note anyway.
Mm-hmm.
So this would be simply actually adding more time and effort, but it would be a great tool to have to make sure you didn't miss anything.
Mm-hmm.
So I'd recommend this would be used as a checklist, not as a document that needs to go to the patient.
Okay. Makes sense. Dr. Brooks?
I have one comment at the bottom where it's accepted for return transfer. I mean, we were under the impression that that's not possible. That, to transfer a patient from Albany Med to a community hospital because they don't need advanced care, that we've not been able to facilitate that.
Right, what happened was, we made an agreement that if we sent somebody for endovascular treatment and it wasn't done, that we would accept them back. But the very first time it happened, we found out that that patient was at the same level of care, and you can't transfer back somebody who was at the same level of care where they currently are, which was Albany Med, and coming back to Ellis. So that was a glitch.
So the conversations that I've had so far with the medical director's office that have gone around that have basically said that absolutely patients can go from one stroke center to another. And that is indeed a possibility. And we've certainly done it with another local hospital on New Scotland Avenue.
But is it
How's that a
the
good way of
ambulance
putting
ride that was the problem?
Yeah, it is.
Because the ambulance won't get paid.
That is
So either
something that they're
one
in the
of
process of working
facilities is to
that
pay
part
the
out.
ambulance, but insurance won't pay for that ride.
Right, that's something that there's a process of figuring that part out.
The hospital, the original transferring hospital is on the hook for that bill.
Mhm.
If, for example, St. Peter's transfers a patient to Albany Med, they have a test done, they get transferred back to St. Peter's. St. Peter's has to pay the ambulance for those two transfers out of the money that they get paid from the patient's insurance company, basically. It becomes part of their Part A money.
But if the patient's transferred to a higher level of care and stays there, that's not an issue.
No, correct. Then the insurance company pays for it. We used to do these all the time years ago down at Greenport. We'd bring them up for a cardiac cath. They'd get cath, they'd have a clean cath, they'd go back down to Columbia Memorial, and CMH paid that bill.
Both ways.
Both ways. Needless to say, nobody ever comes back anymore. They all go up for county. They all stay in Albany.
And they get this one.
That's interesting.
I think that's something really important for us to figure out from a check accounting perspective, because I know the people who are making those trips want to get paid. So let's figure out that part, so we can make sure that all of the pieces fall into place.
But like you said, I know Albany Med, the medical director's office wants to see them go back. I mean, it was very encouraging to that agreement, so.
With that said, I'm sorry, Frank. With that said, I think I'm probably speaking only of CMS, and maybe a commercial carrier might pay that bill. I don't know, but since, you know, the higher payer mix is clearly Medicare and Medicaid, and most of the commercial payers do follow CMS's guidelines. Carol, you might have a different, some more information on that, but I think most of them are gonna follow CMS's guidelines, but I'm talking about CMS specifically. They're not gonna cover
I
it.
can talk to our billing manager, she's brilliant, she's been doing this for a long time, so she would.
But they're definitely not gonna cover it if they go back to the original hospital.
Well, that'd be great. Let's get as much insight as we can, so we can carry the information forward. Frank?
I just had a question, and this is really out of the realm of EMS, but if it's ED to ED and then ED to ED, what's happening with that next ED visit, the final one?
You mean which ED provider's actually getting paid?
Yeah, I mean, I'm just curious, so, what happens with the insurance and the whole, I mean, I don't know, Sam or Bruce or Don,
Well,
what you're feeling
the
going. I
procedure-
mean, I have no idea, it doesn't matter, we'll see the patient, it's not a
Well,
problem.
they're probably gonna get admitted back, but if they come back to us, they're probably gonna go get admitted.
But they're not gonna go from the ED to a floor.
No, they're gonna come back and have a second ED visit.
Why?
Or they've
I mean,
already been
what would be,
I don't know what's been happening.
from my perspective, what would be optimal is if they come to my emergency department, say you transfer the patient to, over to Dr. Boulos, right?
Right.
Dr. Boulos is the accepting. I receive that patient in the emergency department and send that patient down the hall for a CT angio, CT perfusion. The angiogram demonstrates a cutoff, but the perfusion shows a completed stroke.
Right, okay.
I would pick up the phone and call my transfer center and ask my transfer center to arrange a return trip to St. Peter's for a direct admission
The
to stroke.
hospitalist or whatever, okay.
So hopefully it would go straight past you,
Do we
the
know
same
if
way
that's
I
what's
would hope.
happening? I haven't had one of these.
I've had one that
Heard
came
about
back to us in ED.
it. Okay.
We can
I mean,
all hope.
that would be ideal, I mean, that would be better
I
for
hope
the
it goes
patient.
that way.
Basically, when they go down with the name of the accepting physician for a potential return. So if Dr. Brooks sees them in ED and sends them down, the note with them going down says patient is accepted by Dr. Brooks for return admission if necessary.
Would you take them directly to the floor if they came back?
Sure.
Yeah.
There's no need to.
There's no need to go back to emergency.
Did you guys
We'll
receive
send them all
from
down.
our transfer center as ED physicians and accept them
back to your facility, because it may just be something from our access and transfer center, we need to correct to say, no, these are gonna go back to the neurology.
Well, I mean, you just probably call the, like, for instance, the Alice Transfer Center, they give the neurologist on call and say, this patient was sent down here, is coming back because we have nothing to offer, and we admitted him for.
I mean, it sounds like it's just a little education that needs to be.
Yeah,
Because
Makes sense that the hospitals need to be in the loop.
Right, we need to get those guys in.
Yes.
Accepting.
Correct.
They still may end up back in the ED because of capacity issues, so
Sure.
it's, you know.
Yeah.
But in that case, shouldn't they sit with the sending ED until they get a bed?
Say again?
Wouldn't they say in the sending ER till they get a bed?
That's a terrible idea.
It's
a wonderful idea for me.
But it is the standard. It may be a terrible idea, but it is the standard.
Yeah.
Yeah. Yep.
So we need to get our hospitals on board with it.
To know that this is gonna happen a little bit more.
I think the most likely scenario, though, the question about the finances, the most likely scenario is on that transfer back scenario is the original ED visit, let's just use St. Peter's Albany Med. St. Peter's ED visit gets paid, the Albany Med ED visit gets paid. They don't go directly back to the floor at St. Peter's, they have to come back through the ED. That second ED visit probably doesn't get paid. But there's nothing you can do about that.
No, I
mean,
agree.
you know, it is what it is.
Be nice for them to do
Yeah, I'm less interested in making sure that, and, you know, forgive me, fellow physicians, but I'm much less interested in making sure the physicians get paid for that extra visit than I am in making sure that the ambulances doing the travel back and forth are gonna get paid.
Correct.
Well, the most likely scenario is the ambulance and the facility won't get paid. The physician probably has a higher chance of getting paid than the facility and the ambulance. But I think all three would not get paid on that third visit.
Mhm. Yeah.
I'd also be worried that there's one more piece that I'd be concerned would happen, and that would be that ultimately the patient gets a bill for all this ambulance transfer and stuff, so I think we need to make sure that it does, in fact, at worst case, go to one of the facilities, because I mean, if we're billing our patients for this directly,
Mhm.
that would be detrimental to them.
Yeah. I think the transfer from the outside facility to the med is the easiest one to say that works. It's the return trip from the med, that's something that we'll work out internally in order to figure out all the moving pieces, because luckily we only really have one ambulance to figure out how to make sure that they get paid. So I'm gonna pass that information right back to the medical director's office and make sure that we're covering those bases and figuring out how to do that.
Sounds like the procedure got more expensive.
What?
Sounds like the procedure got more expensive.
All right, that was absolutely fantastic. I think we've got a couple of elements of business for us here. We have some future pathways, and hopefully this will work. Anything else to add on the perspective of stroke before we actually move on into our original agenda? Well, I would suggest that everybody grab another cookie, stretch your legs,
Get some sugar.
say thank you very much to our colleagues from the stroke services who came to join us today. And let's reconvene in 7 minutes to have as quick a business meeting as possible through what unfortunately is some pretty important stuff. Thank you.
Just so you can park it.
You look healthy, man. I'm not. Gaining weight from anxiety. I took every antibiotic. No, it's okay. It's going all right. Sorry about that. You know, the thing on the phone, but our staff upstairs.
Why didn't you say something?
Yeah.
Why didn't you throw something?
Yeah, exactly. I did picture one picture, one second, so I just plugged in the picture and not too far. So good, no, I wasn't worried at all, no, I understand.
There's been various years, of course, I know they want to use the Sean score, which is an inclusion score based on respiration, a number of other things. It's more for nurses. And if they put that score, and we do it, let's say we don't do it in the ED, we haven't approved to do it, but we can't handle it as the inpatient. Now, if it's a deal, so for peds,
is encouraging us to forward kids just like this one to you. So, you know, we're receiving a mixed message. I'll go to the status meetings and say, send me patients, and then I call the transfer saying no, no, no. And also I have to say,
You actually have some
it's faster, and they just say, you know, what do you think, doc? And they accept whatever you say. That's the way it is. Now, maybe it's not sometimes, but they accept it. I mean, this one, they just sounds like,
did you know?
I'm sure she's like graduated.
Oh no, we're yeah, not an ER.
No,
but it's
nice to call that tonight.
You don't really cover it.
No, I haven't talked to you.
We just talked to you about it.
Yeah, exactly.
It's like Bruce said anyone.
Yeah, which really, we don't even care about. It's like,
I know, I was there.
Did you or did you not send these? Yes, thank you, bye. That's all I want to know.
I know.
It's great to see you.
You too, man.
Take care. Have a good holiday.
Okay, man.
Touch my head, I'm plugged in. I don't know what to do.
That's another speech. You're sitting there in New York, waiting for a transfer. And so then, why am I going? It's not good for my patient. I'm going. I don't think I'm ready to do what's wrong, but unfortunately, that's not the case. And I'm not bashful. Personally, I don't go to any hospital. Most of the time, but there's a lot of factors. I always think
Hey, Dean, can we turn that on?
I got a phone call. It's on. He's probably there's a command something, you know, I'm supposed to just
So I saw, didn't see a crash. Oh, my. And by the way,
STEMI, stroke, trauma, sepsis, and then we're gonna figure out so but we're gonna try to work on that. I love this, you know, I said, what time you have to sign off? I said, we'll find out. They sent us back as,
I don't know what's going on.
Yeah, can you project that thing? Get my projector out real quick.
Usually there's like a button that tells your computer to project on both sides. Is it?
yeah, but this will, you put the information this is the highest degree that we would offer.
Brilliant.
Perfect. Where's the other two? Reviewing authorizing Sebastian.
So we're looking at simply there way. But there's an endotracheal tube adapter for the amniotic stuck in it. And then there's a little thing that's what works. Plug that into the catch so it's a way to triage.
So I don't know.
You put 15 liters of oxygen. That's actually
That's the best I can do.
Why do we not know that?
That's a lot of money. Yeah, exactly. I just simplified it. That is believe it or not, endotracheal tube
That's a good idea.
I keep it in a little plastic bag, little thing with some jelly with it. So
Is this the new code idea? Is this the new code idea? Stick there and spin the dial? Past vaccination?
yeah, I just wanted to talk about that for 1 second. I actually was supposed to talk about today. This was the one piece that is worth talking about for 1 minute. So I just wanted to grab Mike just to show people. It's another way to do that. Instead of putting the nasal cannula prongs in, which works, that works better. So you basically can drop your sats for that. It's perfect for dough heads, Santa Claus kids.
So what is...
I'll explain those pieces in a minute. Okay. Basically, it's just simply an endotracheal tube top where the airback goes. You know, there's a little piece you open up and on or breather mask. There's a little plastic piece you always throw away.
Oh, yeah.
That's what that is, plugged in there. And then you just attach the O2 tube to that rather than to the mask.
Is that what that piece is in there for?
Yeah.
To do this?
To do this. Well, not to do this, but to apply.
I think she did like
Reese's.
and then like
It's mostly Reese's.
and then like a tiny little bit of Hershey at the end.
Adapt to that piece.
It's way
But anyway,
disproportionate, yeah.
Michael, you're late, so I'm going to steal 1 minute of your time. I have 1 minute. That I
All right,
steal.
1 minute for Dr. Ushkow.
Thank you. All right. There was a whole list of things we were going to talk about, of which I'm going to talk about none of those, but just one thing that I had a picture because I brought my computer today I wanted to talk about. You all know about apneic oxygenation. You all know about pre-oxygenation, and you know right now there's active discussions regarding MFI/RSI. I just want to show you another mousetrap. I'll even go as far as say a better mousetrap to apneic oxygenate somebody. And it's something that's in all your departments right now for free. It's in all your EMS agencies for free. You just have to sort of pre-package it. So right now, sort of standard apneic oxygenation is you put on the nasal cannula and you turn it up to 15 liters and you go about your business on however you're going to intubate the patient. The issue with that is if the tongue falls back, which is what happens when you paralyze somebody, the oxygen's going nowhere. So this is a device that maintains their airway no matter what, and it uses the pharynx as the reservoir, similar to a non-rebreather mask. So what you're looking at is a typical nasal trumpet. This piece is the standard top of any endotracheal tube. This is that little plastic thing when you open up a non-rebreather and you throw that plastic thing away and you never know what it's for. That's what it's for, okay? So you just save them rather than tossing them in the garbage. And we all go through many per day, so in essence it's free. Also your endotracheal tubes which expire, don't throw that piece away, save them. Or the ones that you may intubate, you get everything ready, you don't use it, you just take the top off and you keep it. You keep it in the bag with some Surgi Lube, all ready to go. I don't do it in every patient, but I do it in all my Santa Claus faces because you can keep their oxygenations due to passive oxygenation for 20 minutes with this. Because you're blowing 15 liters, you set it at 15 liters, continuous. Think about where this sits in the pharynx. And they never drop their sats at all. Now obviously this is not what you want to put together while you're about to intubate somebody. You have to have this pre-packaged, ready to go. You don't need to have large bore. You're not going to be using it for any more than a minute or two just while you're intubating, or God forbid it should be a disaster airway for 5 minutes. But at least it's there and the patient's getting passive oxygenation. So I just wanted to show
Go through the construction at the top again.
Sure. Standard nasal trumpet. This piece right here is the standard top where you connect your ambu bag or your end-tidal CO2 detector, even better, on top. Then as you open up your non-rebreather mask, you're always throwing away that little plastic piece in the bag. That simply pushes into where you would connect your ambu bag. And then this has the little Christmas tree that this tubing which comes with your non-rebreather mask uses. So it's standard O2 tubing. That's all it is. Double female.
It has
So
it looks like the piece, it basically looks like the piece that's on the ET tube.
It makes it a simple face mask.
It makes it a simple face mask.
You pull the bag
You pull the
off.
bag off and it makes it a simple mask.
It comes in most of them, not all
Okay.
of them. Not every manufacturer gives you that.
Maybe not in the.
everybody get the concept? Because then I'll let the meeting go on. All right, so if you want, try this on your next go-ahead patient. Don't forget to use Surgi Lube. If you want, you can take the time for Afrin and squirt it in, but usually we're not sort of in that scenario.
I'll save you some.
So there we go. I just wanted to show you that picture. It works beautifully. We don't need to write a new protocol. We don't need to do anything. It's just another way to put nasal prongs in somebody's nose. And they can't lose their airway.
Bruce, do me a favor, send that picture around to the group right now. Dean, do it for him.
Make it happen.
Okay, can you go fix your email?
All right, guys, Bruce, that was awesome. Thank you.
You might as well be shopping in this.
So there's a couple of quick items of business. One important one doesn't seem to have gotten printed out unless it's sitting over there. Is there? No. No. Okay. I'm going to send around the regional restocking form. One of the things that was supposed to go around to everybody was the regional restocking agreement, which Dr. Bosco wrote in 1996.
1890.
Yeah, something like that, something like that.
Must really be looking old in my.
I get that all day at work. Thank you. Somebody else taking over.
So, the regional restocking agreement will come around to everybody by email. If you can take a look at it, bring it back to your facilities so we can then renew it this year. That would be important. I think that will make a significant difference in some of the areas where we have had some issues with restocking. So all of that said, did everybody have a chance to review and approve the last minute's meeting minutes? I'd like to thank Dr. Doynow for chairing in my stead. I appreciate that. Thank you very much. EMS World Expo was great, with the exception of getting some complaints from Bowman and Wood.
The worst thing they could have done was created a Facebook-like app where we could exchange comments about our displeasure over how full the rooms were, because we did that.
Yeah.
Yeah.
And it was, some of the room choices that they made were pretty poor.
Yeah.
And they read them.
They did actually read them.
They did.
And
we got the name with the head house.
The bosses asked for us by name to come down and meet with them and voice our displeasure in person, which we
Excellent.
did.
I have no doubt you did.
We did. We were pleasant. They were pleasant. It was
Excellent.
fun. But I mean, you know, for those of you that know the people that are on the national scene, and his name just went right out of my head.
Steve Berry.
Steve Berry, you know, has done the cartoon. I'm not an ambulance driver. He's been doing that thing for years, and they had him speaking. I don't know what, 3-4 different sessions. They had him in a room smaller than this. And if you've ever been to EMS Today, which is where he used to always speak, I mean, he would. He
fills a room of 1,000.
He would fill the main hall and have overflow and people sitting around the outside edge. And they had him in a room smaller than this. You literally couldn't even get to the doorway to get your badge scanned. It was a joke.
And a person speaking about mobile integrated health in a place about the arena, which I'm great, but you know, most people really don't care about that.
Yeah, I mean, it's important. I mean, you know, it's not that topic is not important, but let's be real, which is going to draw the bigger crowd. So there were several times where we went to our first, second, or sometimes I think once even our third choice, and we couldn't get in the room. And once we even went and got our badge scanned and went and sat in the couches out in the lobby and just sat and had coffee and BS because we couldn't get in the room to see or hear a presenter. So it was a bit frustrating. You know, spend a lot of money to travel halfway across the country, and anyway. But they were very receptive. I mean, which they should have been. So anyway.
We will add, the funniest thing that I got there was actually a series of complaints from Captain Wood regarding the dress code and language of one of the speakers, which I found hilarious. I believe you referred to him as a woodchuck.
You know it's bad when Brian Wood refers to someone as a woodchuck.
And when they complain about their mouth.
All right, all of that said.
And he was a physician.
He was. He still is.
He probably still is.
He still is. With the exception of the correction of one spelling error in the minutes, does anybody have anything else to add to the minutes? All approved? Excellent, thank you very much. Old business to start with. Let's just start with, correspondence. We have some correspondence noted on here. I am not going to read the discipline into the record. The academic committee, if you would.
Okay, very briefly, well, I know Brian's giving it again, but Brian gave a very good talk on combining EMS charts. MFI survey went out. There was nothing that was overly exciting, to say the least. It was suggested that we do additional survey to see if ketamine was used, what their thoughts were about their use of it. Other than that, the exam for the protocols is 101 questions, Deb mentioned. It will be a 50-question exam. It will be for new providers, not for current providers. The study guide is available. The app should be out sometime in January. And after January 1st, we're expecting within 90 days that everybody will have been signed off as having reviewed the new protocols. That's basically it.
Okay,
I don't think I missed anything.
excellent, thank you. Any other comments from the academic committee? Brian, do you want to do your presentation real quick?
I can, I mean, it's mostly the same people as that.
Yeah, and it's only docs.
Yeah, but it's the docs who actually weren't here.
Yeah, and, I mean, I can do it real quick.
You should do it really quickly.
I mean, just go through it. It's the same thing that I talked about like 4 months ago. I couldn't come because I was down at Expo. But just to show you more about it, just go right through it, blast through it. And this is part of that project we were talking about consolidating our electronic charts in areas where we're running crews that are consolidated in an effort to try to eliminate those discrepancies that might jeopardize or ruin the integrity of our patient care based on those discrepancies, and perhaps improve the treatment by looking at just one chart that paints the picture instead of potentially 2 charts that may paint 2 different pictures. It'll streamline the process for crews that are consolidated. In some cases, we're running, you know, a county person and a BLS person on one ambulance, and it will provide some cost savings. So right now, what we do is we're actually making 2 EMS charts. The county does one, and in this case, it's a Delmar Bethlehem example. But if you can see right here, right off the bat, we have a fall victim and we have an unconscious fainting. And those charts are actually the same patients. And you can see the discrepancies. This one says the EMD code coming from the same dispatch center was 31D3, it's 31D4 up there. So right off the bat, within the first group of pages, we have some pretty significant discrepancies. Go ahead. This is the actual call. The ALS chart showed a duration of the complaint for 8 hours, BLS of 15 minutes. The complaint on the ALS call was a weak person with diarrhea. The BLS chart showed a fall. Past medical history was extensive on the ALS chart with none on the BLS chart. And then those differences down through with the chest, back, the extremities, and the skin findings. So actually, if you read these 2 charts, you'd think they were 2 completely different people. So it combats a person that was a fall from weakness, and but those were the substantial differences. So what we do, or what I'm proposing to do, is in any agency that works with us, they would be able to apply to the region to be upgraded to an ALS level based on a contract that they have with the sheriff's office, or in any other event. So it could be anybody in any of the regions. If they have a contract with an ALS provider to provide 24/7 ALS care, they would be able to be recognized as an ALS provider. In this case, I used Rensselaerville for a control group, mostly because it was small, and the laughs because it was my mom and dad, and I only had an even smaller group of people to control. So in this case, this is a Rensselaerville chart with me as the paramedic, and we did a breathing difficulty, which was a pneumonia patient. I did the whole chart here. It's actually done, as you can see here, on Rensselaerville's EMS chart, but I did it as an ALS chart with me as the county provider being the paramedic. Go ahead. And then you can just see the crew, laugh as you will. It is my mom and dad, and me as the ALS provider. Okay? Next. So this one here is a call that actually just happened 2 nights ago. Tim Robley was the paramedic from the county. Again, my mom and dad is the ambulance crew. And this was a BLS call. So this was still also done on a Rensselaerville chart. 1 chart was completed versus having 2 charts. This chart was completed in its entirety, and then at the end, go ahead. You can see that Tim was able to identify a couple of issues with the documentation, and he added in a set of vital signs, recognizing that there was not a set of vital signs on there. And he also recognized that the BLS crew kind of painted a picture of a patient who was in pain and might benefit from some pain management, and they were, and he did not write in and give pain management. He justified why he did not do that. So he was able to add an addendum onto the chart, clarify that, and then move on. Okay. So you can see in the cost savings, Delmar Bethlehem pays about $8,200 a year, and we're paying $8,000. So we're combined paying, you know, $16,000 for doing 3,352 charts. But because we duplicate those charts on every single patient, we're doing 6,704 charts in that 12-month period. So the requirements would be basically they would come here, fill out the application to be an ALS agency, and they would have to have that contract in place to show that they have around the clock coverage. The ALS agency would be responsible for doing the appropriate QA. The medical director, in our case, Dr. Doynow, would have to be the associate medical director from all the participating agencies, and then you guys would approve it. So, quick and dirty. Any questions?
I got one. I didn't
You
ask
had one
last
last
time.
time.
I know, and I apologize. Can the medic change what the EMT has wrote? Can they go in and like say delete or add to that, or is it just an addendum at the end of it?
I asked my guys to do an addendum, so it's clear what, so there's no changes that you want to change something. They can go on and explain it or fill it.
But they
out.
could technically
They
change
probably
it.
could, sure.
But just more of an addendum to say, this isn't really what the picture was, this is what the picture
The
was.
software would allow you to change it, but from a policy standpoint, it should be an addendum.
I strongly encourage that policy, we do not delete from somebody else's
Yeah, I
work.
agree.
Well, the
Actually,
chart-
that was
yeah,
just an expert witness.
I don't do that now, so I won't allow those guys to demote a chart and make a change and then do it. I make them correct it in an addendum so that there's no
Well, to,
changes.
to clarify the difference though, in this situation, that chart had not been locked and finalized yet, so it was not an official chart yet when Tim did what he did. So it's not like there would have been a chart that had been faxed off to some hospital and then Tim made a change to it. You know, it had not become a real chart yet.
Both providers have to sign off on it.
Right. So,
Sam?
My question for this body, if the ALS designation is made for that associated agency, it's contingent upon that ongoing relationship, correct? So if that ongoing relationship, for example, you guys didn't, contract renewal didn't happen,
Yep.
is that ALS designation automatically suspended?
I think that would be the way we should pass the motion, Sam.
And
'cause I think,
that's what I'm suggesting.
yeah,
That I see no problem with this, contingent upon that relationship continuing, unless that associate agency were to independently start hiring its own medics and do something differently.
Yeah, I think that my question will be after this is done, it was a very simple application that we signed. It was basically the CEO signed it, the COO signed it, and then the medical director signs it. Maybe in there needs to be something up on signing that you acknowledge the fact that if the event that the contract is null and void or runs out, that you are no longer, you are relinquishing that responsibility or suspending it. I think that's.
Or you have another acceptable ALS agency.
so you have to redo it
Yes,
under the other one.
exactly.
Yeah, I
have to
think
come back
that's
to the back for
important.
approval.
It would have to come back to Remo for, yeah.
Yeah, that would have to come back, and I think the thing that's important is that within the language, it says, you know, Rensselaerville Ambulance will not maintain separate narcotics.
Yep.
Because if they can't have narcotics, they can't be an ALS agency, but narcotics will be provided by the contracting.
I'd be
Yeah.
willing to work with Tim on that to maybe clean up that application a little bit to address those things, so.
Brian, I can send you some verbiage that we routinely use for that
Okay.
section.
That'd be
of it.
perfect. Awesome, thank you, Mary. Yeah, I think this is a potential home run. Sam, do you wanna make a motion?
I'll make a motion that we accept, Brian, tell me exactly what you're asking for.
It's a consolidation of charts, so, you know,
And designation of ALS
yeah, so
status.
it's, right, so it's a designation of our participating BLS providers to become an ALS provider, so that we can consolidate the charting process into one medical record.
Through an agreement. Contracted agreement with an ALS agency.
And I have that contract if anybody wants to read through it or whatever.
All right, so I'll make the motion that we, as a body, allow designation of BLS agencies to provide ALS care through an associated agreement with a designated ALS agency within the region, and that ALS designation is contingent upon that ongoing relationship.
That sounds great, Sam. Second? Okay. Everybody in favor? Awesome. Jay, did you actually get that?
Best I could.
I got it too, so.
Can you come to
after.
Mexico and make all motions from now on?
What I would suggest is that each one of these contracts that is passed then comes here so that we can note it as an item of business just to make sure that there's coverage at that level as well. But this is an absolute home run. Now, for physicians in the room, we don't have the power to actually have our nurses chart with us, so there's actually only one patient chart. Maybe someday, let's see.
Just a point, just to cover Rensselaerville, if someone could send notice to Dan Clayton in our office that you sort of back approved them, just so they're covered for billing purposes.
Absolutely.
Since the trial, as a trial.
Jay, would you note that is just something we need to make sure to do, and Dean, can you make sure that actually happens? Thank you. Could you repeat that?
Just ALS notification needs to go to Dan Clayton for Rensselaer.
Notification of all ALS associate agreements goes to Dan Clayton.
As of the date, the trial began.
Were you making that during the trial period or the pilot period?
No, forever.
Here's the problem.
He sends notification.
He sends notification a little bit. So just to cover that, he does it like quarterly, but I don't know what quarter he was on.
Eliminate a potential billing red flag coming back from you from that.
Awesome. Thank you, Mary. All right, nothing from the CMAC or the SEMSCO. We will have, I'm sure, copious information in February. Do I anything of note, Rob?
So we ran the numbers for the arrival time, the EMS transfer at the hospitals, and this is just purely with EMS charts data. That's all we could get. And it's not as overwhelming as we're looking at. I mean, there definitely are outliers. There definitely are cases of significant weights, but out of the three larger hospitals, Ellis, Albany Med, and St. Peter's, one is 18% of patients within 15 minutes. One's one's 14% within. One is 82% within 15 minutes, 86% within 15 minutes, and 90% within 15 minutes. And then the longest is greater than 21 minutes was 5%. So that greater than 21 minutes could be an occasional 3 hours. We didn't run that way. We maybe look for what the range is. I don't have that. But we're going to rerun it again in September. In the meantime, the more data we get, the better we get. We may be able to show some other difference. We're also going to rerun this on it was run on a day, evening, and night, but not day to day. Next time we'll run it on day to day, because we may find more variation between Monday and Saturday than between 3 in the afternoon and 3 in the morning.
Bottom line is, we ain't as bad as we think we are.
Exactly.
There you go. Awesome. Thank you. Any comments? Nope.
Not to
Perfect.
say it doesn't suck to sit in for an hour 45 minutes with one patient, but.
Agency upgrades, there are some. Please enjoy the reading. Public access defibrillators, there are more, which is also good. There are a couple of collaborative quality assurance projects that are going on, and I would encourage you to have your agencies participate, please. Patella reduction, every time the patella reduction protocol is used, there's a link on the REMO website. Please click on that. There are, I think, 5 questions, maybe 4, to answer. It basically is going to give us an idea as to whether or not we're doing a good job with this and whether or not we need to do any more training. So please make sure to fill that out. And there's going to be one there for ketamine as well. So please also encourage people to fill that out after each utilization of ketamine. The more prospective data we can get on the use of ketamine in EMS, the better. This is really the new frontier. It is a drug that has serious potential to change the way we're doing things. Let's make sure we're recording it well.
I can tell you, statewide, very little use.
Right. And that's interesting. You know, for the amount of energy it engendered along the way.
But fentanyl use has gone up.
Fentanyl use has gone up. Gotcha. Do you want to talk about forms or no?
They should, the new and revised controlled substance forms according to the forms, police are in their final stages.
Don't tell me they're actually
Want that
putting that
title.
on.
Actually, what's gonna happen is there's gonna be one form, it's a 2-page form. Don't freak out because half of it's commentary. But anyway, it'll be one form for all narcotics. So if you have fentanyl, ketamine, morphine, an event, you have to fill out as many forms as you have drugs, you know. But I think it'll streamline a lot of it. There's also some more useful information. Was there any increases, decreases, comments, unusual circumstances? This way, if we start to see trends, we can feed it back to the doctors and stuff. And I can tell you that every form gets actually looked at when it comes in.
You know, it'd be awesome just to use that website, so we could just.
The health commerce system doesn't want any part of this.
No, just your website. Just do
Our
yours.
website is ready to crash on anything.
Just input the stuff, let's type down
We
the
tried to
piece of
get it,
paper.
we actually tried to get it into the health commerce system, which is how hospitals report everything.
Yeah.
And they wouldn't go for it. I don't know whether it was the narcotics or the fact that it's at Mike Taylor to negotiate.
Probably both.
So, but we're trying to streamline it, make it easier. We could not get B&E to budge on the quarterly reporting requirements for ketamine and fentanyl. We tried.
Because of all the diversions that we've had.
Yes, do they give a reason? other
They
than
claim that,
that's what we want?
they claim the diversion potential.
They're
Are you walking around with a thermometer for sepsis? Oh, sorry, it looked like,
It's his dongle.
Put your dongle away.
It does anything.
No, the bottom line on the
Mary,
B&E
I want
component,
you
there were significant numbers of conversations with our partners over the B&E. And the Bureau of Narcotics Enforcement has been nothing but collegial in terms of working with us to make sure that we can move these things forward. But in this political environment right now, with the number of opioid overdoses that there are out there, the idea of having them move forward, the concept of reducing oversight ain't happening.
No, and for people who aren't aware, I mean, with the opiate legislation that was just passed, I mean, every physician in New York State that has a license is gonna have to take a course every time they re-register for their license. And a 3 or 4 hour course that's required, like the infection control course is required every 4 years, this is gonna be required every time you renew your license. And it's opioid education. And, you know, it's, like you say, in this environment, there's no way that B&E is gonna back off on monitoring.
But really important to recognize that they were incredibly collegial and really were a partner through this, even though we couldn't, just because we didn't get our way doesn't mean they weren't working with us, you know? So
is it a different form for each
Yes.
of the controlled substance?
You'll do one form for each controlled substance, but the
same
forms
form.
themselves
You just do that
are
many
exactly the same. So it's not like there's a different form for fentanyl, and each form will need a medical director's signature on it as well.
because right now, every form, the ketamine
As
form,
opposed to the
fentanyl.
CEO.
Oh,
who
he's
knows
still
not-
signing, don't worry,
Right.
he's still
Oh,
signing.
that's great.
It's the agent that
Because he
gives
knows so
three
much about
signatures.
what's going on operationally in the organization. I always love that.
Well, MDs needed to have a buy-in because it's their DEA license.
Fair enough.
So,
No, I agree with the MD signature. I just think it's funny that the CEO has to sign.
All right, moving on. We talked a little bit about the restocking agreement, and we'll talk about that some more in February. Hopefully we'll come here with the ability to, once again, re-up that. And one other item of new business is that Empire Ambulance is getting a new medical director. With our vote, it would be John Broderick. John, as you may know, is the Regional EMS Medical Director for Mountain Lakes. Has been Empire's medical director in the Mountain Lakes region for many years, and now is going to be the medical director down here if you all approve. I bring that forward as a motion for a vote, please. All in favor?
So moved.
Thank you. It is also Dr. Broderick's birthday tomorrow, so I'll make sure to pass that along with his congratulations. Any other old business? Any other new business? Thank you all for your patience. This was a fantastic meeting. Motion to adjourn, please. Thank you, Dr.
All in
Broderick.
favor, stand up.